Good afternoon, Francis, Lawrence, and Lee. We'll wait a couple more minutes before we get going. There we go. I had a feeling Jim was going to show up, and then we'll see if anybody else shows up before we get going for today's HiPAM meeting. Okay, good afternoon, HiPAMers. Good to see you all. Happy Thursday. Awesomely. Let me just get through the overview and the science updates, and then I'll hand it off to you for the deep dive today. So Japan continued to climb. Obviously concern for us as they are a trusted safe travel partner, and with everything going on in India, the Indo-Pacific region is definitely a place where there's a lot of eyes on as well. South Korea going down just slightly. However, it's important to note again that, while their 70 average is 670 compared to Japan's, which is close to 5,000, we still want to look at relative comparisons, for their population. And it's not to a point where, I think they've declared success either. So once again, just continue to watch all of our partners in the region. India, unfortunately, has not yet gone down from last week. Where we're seeing more and more reports of requests for oxygen generators, and any support they can get. And thankfully, the international community is sending it there. But once again, like we discussed last week, this is an example of what could happen if you relax too soon and vaccination rates are not up to where they should be. At a national level, thankfully, we are trending down. Our 70 average continues to drop, and hopefully will continue to do so, even as our vaccination rates may be plateauing slightly in different parts of the country. Arizona, California remain relatively constant. Nothing too concerning right now. I know California has some other variants, and from what we've heard, we've discovered, the California variant in Hawaii is definitely circulating. I do not see Marguerite on right now. I know her lab's been working on that. Nevada and Texas, I think, like majority of the states are holding steady, but not truly declining yet. Looking at our Hawaii state trends, Maui County is finally under that 10 cases per 100,000. Percent positivity, we are all the counties and the state overall is under 3%, which is great. Vaccine administration continues to move forward. At least if you look at the numbers on a larger scale for the state, we are seeing news reports where a lot of the mass vaccination sites are increasingly accepting walk-ins. And so what that suggests is we may be reaching a possible point of vaccine saturation, even in a place in Hawaii where our rates are higher than other states' averages. So we continue to watch that in terms of any potential possibility of reaching some sort of vaccinated herd immunity of 70 to 80%. So no issues with testing turnaround time, and with no major changes to our metrics. We're we're projecting for the next 2 weeks just relatively flat or a slight increase in cases, and then relative change in hospitalizations and ICUs. But the good thing is that a lot more of our elderly population is vaccinated at this point, and those are higher risk populations for hospitalization and ICUs. So a lot of updates as usual, and I think at this point we've established that the vaccines work in real world. So unless there's anything major, I tend not to put more of those updates. The three that I want to highlight this week, CDC did update guidance for fully vaccinated individuals for mask wearing, but also for unvaccinated individuals for mask wearing as well. Highlight again what's going on in India and a potential role of variants in their spread, and then a potential maybe game-changing treatment that Pfizer released earlier this week. So this is the next few slides are going over CDC's updated guidance. So if you look at the left side, that's their guidance for mask wearing for unvaccinated individuals. So now saying outdoors, if you're with members of your household or by yourself, it is safe to do these particular activities outdoors. That's that first row. And then the second one, if you're outside, small gathering with fully vaccinated family and friends, and you're unvaccinated, you are safe to wear a mask. Anything else, the safest is still to wear a mask if you are unvaccinated. Now, the restrictions have loosened a little more for our vaccinated individuals. I do want to note that if you just look at the guidance on this cheat sheet from the CDC, it does not paint the full picture of the guidance that they're putting out. So in addition to these options for fully vaccinated individuals, here's the entire list of activities that fully vaccinated individuals can partake in without wearing masks. It's important to note that we still recommend, CDC still recommends wearing masks if there's any uncertainty, especially indoors. So, earlier in the slides, we showed India's increasing trend. Wanted to call out some other additional points. Last week, the WHO said that India accounted for 38% of all worldwide COVID-19 cases. There is an India variant B1671 circulating with other variants to include the UK variant, the B117. And obviously a very, very limited oxygen supply that we brought up last week that continues to be the case this week. And in trying to do a dissection of what led to such a drastic increase in India, some hypotheses include, just mass gatherings after their first wave, and where it appeared that there didn't seem to be a second wave coming in India, and I think just timing wise, there were a lot of festivals in India that really resulted in what you can see now, an exponential increase in COVID cases, especially since their vaccination efforts still are not where some of the other first world countries are. Finally, vaccines have dominated the headlines for 3 or 4 months, and rightfully so. But it's important to have all the as many tools in the toolbox per se, in terms of mitigating as the impact of COVID as much as possible. So as a public health professional, and as many of you are public health minded on the call, prevention is the goal. However, we know that prevention is not always possible. So quick treatment really does a lot of good. And hopefully, once again, I want what this COVID-19 or COVID pill that Pfizer announced, the hope is to be a very early treatment. It's a protease inhibitor. Basically, point is trying to prevent reproduction of the virus, so COVID-19 virus, important to note that this is only a phase 1 trial, so still need to finish phase 1, then go into phase 2, phase 3 before EUA can be even a request for EUA can be submitted to the FDA. However, this is good news because this can be it's a pill and it can be prescribed very early on by providers. So hopefully, where this will be a strong measure or tool for healthcare professionals to use as we're tracking breakthrough cases. And even if a large part of the population is vaccinated, we're always going to have those who have COVID. So really trying to limit the impact both to the person and to the population with a drug such as this. So I just wanted to bring this to the attention of the group. And I believe Merck also is working on one similar mechanism. They announced one at last month, I believe. I will pause for any questions or comments to the science highlights or what's going on. And if I don't see any, then I'm going to hand it off to Lee for him to provide the deep dive for this week.
I guess there's no questions.
No questions. The floor is all yours, Lee.
Okay, can you see the slides I've got up there?
We sure can.
Okay, so I'm going to be giving a deep dive into this paper that came out on March 22nd in the Lancet Infectious Diseases that is relevant to the pre-travel testing program that's called the Safe Travels Program in Hawaii. And let me just about a month ago on Keihan 2 in their print version was a headline: new study says testing similar to Safe Travels may detect nearly 90% of travelers with coronavirus. And then in the picture it says Safe Travels may detect nearly 90% of infected travelers, study says. And then a few days later, in his daily briefing, the Lieutenant Governor, Dr. Josh Green, said Safe Travels has been working. We now know from a study that came out of the Lancet journal, and Lancet is the best journal in the country, basically. They showed that 88% of any case could be prevented if you did a pretest. So this is our pre-arrival testing. 88% of people could be caught before traveling if they got the test. That's why we have not had travel-related cases. Now, when I read this, 88% prevention of any case came as a surprise to me because of prior studies I'd read on that the rate of false negative RT-PCR tests, which are the standard gold standard test for detecting infection with SARS-CoV-2, that this test is estimated to have greater than 30% false negative because of the long incubation period relative to the contagious period. So here's an example in a summary by Hayek of a study by Kusirka et al. False negative rate of RT-PCR SARS-CoV-2 tests. And their quick takes are that tests for SARS-CoV-2 based on RT-PCR add little diagnostic value in the first 5 days immediately after exposure. Decisions regarding removing contact precautions or ending quarantine should not be made on the basis of results obtained in the first 5 days post-exposure and absence of symptoms. Serial testing may improve test performance, but needs to be studied. So, and here's the source paper itself by Kusirka et al. Their results were that over the 4 days of infection before the typical time of symptom onset, day 5, in other words, during the quarantine period, during the incubation period, the probability of a false negative result in an infected person decreases from 100% on day 1 to 67% on day 4. So in other words, 100% false negative on the day that somebody is infected, which we would expect. And then on the day of symptom onset, the median false negative rate was 38%. This decreased to 20% on day 8, 3 days after symptom onset, then began to increase again from 21% on day 9 to 66% on day 21. So this is a very high rate of false negatives from the PCR test on people that are infected with COVID. Let me pause to take any questions that people have along the way. I'm not seeing the, let's see, I'm not seeing the
I don't see any in the
chat.
Q&A or the chat.
Okay.
So we're good to go.
So I don't see the chat, so you'll have to tell me if there's something in there.
Sounds good.
And okay, so but there was other reasons that this 88 prevention of any case description came as a surprise. So besides this rate of false negatives of the PCR test, the Maui departure study conducted by the Department of Health found 7 out of 1,000 visitors with negative pretests were nevertheless infected and at the time of their departure. And Kauai's COVID-19 case numbers before, during, and after participation in safe travels were dramatically different. And you'll read more in the newspaper about the outbreak of COVID-19 on Kauai since rejoining safe travels on April 6th. And then finally, the establishment in Hawaii of the variants of concern during the safe travels period. And just about all the ones we've heard in the news are now established in Hawaii. So B1 429, B1 17, B1 351, and P1. Those are the California, the UK, South Africa, and Brazil variants of concern. So what is this apparent contradiction? Let's take a close look at the Lancet study. So here's the study that was cited in these newspaper articles. It's by Yang et al. And it's routine asymptomatic testing strategies for airline travel during the COVID-19 pandemic, a simulation study. So here's what they did. They did a microsimulation of SARS-CoV-2 transmission in US domestic airline travelers. And what they did is they used publicly available data on COVID-19 clinical cases and published natural history parameters. They simulated a travel period that's 3 days before travel to 2 weeks after travel. They assumed that individuals who tested positive before travel were not permitted to travel. And they looked in the simulations for 2 different outcomes. Their primary outcome was the cumulative number of infectious days in the cohort over the travel period without isolation or quarantine, and the population level transmission risk, and the number of infectious people detected on the day of travel, which is passenger risk of infection. So the chance that if you're a passenger on the airplane, that you're going to get exposed to somebody with COVID-19 who's tested negative. And here were their methods. So they assessed then 5 testing strategies. So they plugged in 5 different strategies into their simulation to see what result would be on those 2 outcomes. And so the first strategy is the essence of the Safe Travels program, which is an anterior nasal PCR test within 3 days of departure. The second study is the same, plus doing another test 5 days after arrival, and in between doing a 5-day quarantine. The third strategy was using a rapid antigen test on the day of travel instead of the PCR test through the trusted partners that the Safe Travel program is using. And then the fourth strategy was a rapid antigen test on the day of travel, plus a PCR test 5 days after travel, plus 5 days quarantine after travel. And then their fifth strategy was no pretest, no quarantine, just one PCR test 5 days after travel. And here are the results in their table. Now, the print is pretty small, so I hope you can see this. But so here's the top row is no testing, no screening. So this is just completely opening up to travel the way it was before the pandemic. Then here are the 5 strategies below it. So this white column is the PCR test within 3 days of departure. The Safe Travels program uses. The one underneath that is where you add a second test 5 days after travel and a quarantine in between. And the white row below that is, instead of the PCR test before travel, you just get a rapid antigen test on the day of travel. So that can be right at the airport. And then below that is the rapid antigen test at the airport, plus a PCR test within 5 days of arrival and a quarantine in between. And then finally, there's no quarantine, no pretest, just the PCR test 5 days after arrival. And now let's go to the relative reduction column, and you can see the results. That the Safe Travels program, the PCR test within 3 days of departure reduced the amount of exposure of the destination population by 36%. Now, where did that 88% come from? That's over in this far right column. And this is the reduction of exposure on the day of travel only. So this means at the airport, on the airplane, and then in the destination airport, and then shuttle to the lodging or whatever. So this is on the day of travel, you get an 88% reduction. But when you include all the exposure in the days after that day of travel, it's only 36% reduction. Okay, so what happens if you add onto this a second test and a 5-day quarantine? Then the reduction in the exposure of the population goes up to 70%. Meanwhile, because this is all measures taken after the day of travel, it doesn't affect this day of travel at all. So that's still 88%. So when you include the second test and a 5-day quarantine, the reduction of the population exposure goes from 36% down the reduction goes from 36% to 70%. So if you subtract that from 100%, that means the pre-travel test is allowing 64% of the exposure to the population to occur. And whereas if you add the 5-day test and quarantine, then only 30% of the exposure to the resident population is occurring. Now, these two next columns two next rows are interesting, where they swap out the pre-travel PCR test for just a rapid antigen test at the airport. And there we can compare the numbers to the equivalent with the PCR test, and you go from the 36% reduction to 32% reduction. So that's not very different. On the day of travel, it goes from 88% reduction to 86% reduction. So that's almost identical. And then when you compare that to when you also add the 5-day quarantine and second test, the reductions are 70% and 63%. So these are on rough order of magnitude. So that doesn't look like there would be too much of a hit from swapping out the trusted partner PCR test within 3 days of travel just for a rapid antigen test at the airport. Finally, if we look at the last strategy, which has no pretest, no quarantine, just a PCR test within 5 days after arrival, and then if somebody tests positive, they have to quarantine after that, you get a 42% reduction of the exposure to the population. So that's roughly comparable to what the PCR test, the pre-travel test, is doing. So according to these expectations, all the travelers could completely skip the pre-test, just get on the plane, come to Hawaii, and 5 days after arrival, take a PCR test, and it would protect the resident population by roughly the same amount as the pre-travel test. So that's one of the implications, surprising implication here. Any other questions coming in? If not,
Hey, Lee, we
yes.
have a couple from Jim. So first one, a few minutes, or about 5 minutes ago. So he asked, so aside from the Lancet study, the false negative rate for PCR itself calls Lieutenant Governor's evaluation of safe travels into question, correct? Question mark.
Well, yes. I mean, it seems to be the governor the lieutenant governor has interpreted this result for the day of travel to be the result for the entire period of travel while the visitor or returning resident is in Hawaii. So it's not reducing any case by 88%. It's reducing cases on the day of travel by 88%, caused on the day of travel. Does that answer the question?
I think so. And then a follow-on question from Jim. So per the Lancet study, could we achieve the safe travel results with a rapid antigen test instead of, or we could achieve the safe travels results with a rapid antigen test instead of a PCR test? Would that be a correct statement?
Yes, that's how I would interpret the study. That's comparing the first strategy with the third strategy. And so you have 88% versus 86% on the day of travel. And then for the rest of the 2 weeks, you've got 36% versus 32%. So it's a little bit worse, but not dramatically worse. And it's within the margin of error for these estimates. So let's take a look here. So here's how the authors interpret their results, that routine asymptomatic testing for SARS-CoV-2 before travel can be an effective strategy to reduce passenger risk of infection during travel, although abbreviated quarantine with post-travel testing is probably needed to reduce population-level transmission due to importation of infection when traveling from high to low incidence settings. Further, they say testing strategies designed to minimize passenger risk of infection will focus on pre-travel testing, whereas strategies designed to reduce population-level risk transmission will include both pre-travel and post-travel testing. And in their discussion, they say, we found that both pre-travel testing with a rapid antigen test on the day of travel or PCR testing within 3 days before departure could reduce the risk of SARS-CoV-2 transmission during travel, with the majority of benefit being seen by other travelers who might otherwise have become infected. We found that the addition of post-travel testing and abbreviated quarantine for 5 days could provide further benefit at the public health level by reducing importation and ongoing transmission in the destination city, especially if traveling from high to low incidence settings, which is certainly applicable to Hawaii. So let's look at their simulation results. And this is their figure 1. So we have these 6 panels. The first panel in the upper left is the no testing strategy. This would be completely open travel policy. And then we have strategies 1, 2, 3, 4, and 5 below it. So what this shows is that 3 days before travel, so this line is the day of travel, this dotted line. So 3 days before travel, we don't have any contagious individuals, but that increases as we get to the day of travel, and it keeps increasing over this period. So this line plots the accumulated exposure of people around the traveler to COVID-19. And so this accumulated exposure just keeps going up, and around day 10 or so, it starts to flatten. So there's not much more exposure after that. So this is our completely open travel simulation. Now, this the top middle is the curve you get for the Safe Travels program. And so we see that when you screened out all the people that tested positive in the 3 days before the travel, then the amount of exposure that accumulates takes a while, and there's almost no change between 3 days of travel and the day of travel itself. So, but then in the period after arrival, all the exposure goes up, and it really ramps up around a week after travel and then flattens down. So the third one is if you add the quarantine and second test to your pre-travel test. Over here is the equivalent of the Safe Travels program, except where you do an antigen test at the airport. So there you see the exposure goes up, and then when you screen out all the people that test positive at the airport, then it stays flat for a while, then it starts going up again 7 days after that. And here is that antigen test at the airport plus the quarantine for 5 days and the second test. And the last one is the amount of exposure just with no pre-test, no arrival test, no quarantine, but just one test 5 days after arrival. So everybody who tests positive at that time goes into quarantine, so they're not exposing anybody. And then you get this curve here, which is similar to the curve over in the beginning here after the test. In that there's only a small number who escape the positive positive test screening at this point. Now, to compare these curves, I've done an overlay. So I've put the 3 strategies together. So the top one is the no testing strategy. The middle one is the PCR test 3 days before departure, the Safe Travels program. And then this bottom line is the Safe Travels program plus a second test and 5 days of quarantine. And here we can see where they're getting the numbers that were in that table earlier. So again, this is the cumulative exposure of the people around the traveler each day after the test. Each day starting from the -3 days before the trip day. So trip day is 0 here. And then 14 days is the maximum. So what we see here is this 88% reduction is for the day of travel, this dotted line, how much the curve would have been with no testing versus what the exposure is when you've done the pre-test. So this is your 88% reduction. Now, something not examined in the paper, but which you can do by looking at these graphs, is to ask, what if a traveler only stays 5 days? So all these results at the end assume the traveler is staying for 14 days. But I recall that an average stay of visitors in Hawaii is 5 days. And so how much extra exposure would we get from 5 days from a 5-day traveler? So this top line is again completely open travel, no testing, and then here's the strategy from the Safe Travels program. And so the Safe Travels program is reducing the exposure by about 59%. So that's pretty helpful, but it's not 88% and it's not 90%. It's about 59%, which means some 41% of the exposure of the population that we would be getting from no testing at all, completely open travel, we are getting with the Safe Travels program for infected visitors that stay just 5 days. Now, when we go out 14 days, so this is relevant to returning residents that just come and stay, and the whole 14-day period is relevant to how much exposure they're giving to the local population. And so here we see the result, the level at no testing. And here is the PCR test 3 days before departure. So the Safe Travels program would reduce that exposure by 36%. So returning residents coming back to Hawaii that have a negative pretest, the resident population is still getting exposed to 64% of the COVID-19 exposure that they would be getting if it was completely open. If you add to that the 3-day, add to the 3-day pretest, the second test and quarantine 5 days after arrival, then we reduce the exposure of the population from returning residents by 70%. Okay, so this is the basic result of the study. So here's the implications. So relative to completely untested, unquarantined travelers, the Safe Travels program is expected to reduce residents' COVID-19 exposure from 5-day visitors by 59%, expected to reduce residents' exposure from returning residents by only 36%, and adding a 5-day quarantine and second test is expected to reduce residents' COVID-19 exposure from returning residents by 70%. And here are the sources. So the slides will be available on the HiPAM website afterwards, and you can go check out the source papers for this. So do we have any more questions?
Thanks so much, Lee. We'll wait a minute or two for any follow-on questions. This was very helpful breaking down one of the more in-depth modeling papers, realistically, how they would implement any type of pre-post travel tests, including quarantine. So thank you for doing that and also applying that to Hawaii. Any other questions for Lee? And Jim, apologies for misquoting your first question. Oh, question from Francis. Were there any other measures such as masks, social distancing considered in this modeling?
So this assumes that all these measures are applied equally to all the different strategies. So so it doesn't, the absolute amount of infection of the resident population is not evaluated, just the amount of contagiousness, the days, actually they do in terms of days of exposure. So they're comparing the days that a traveler is contagious for these 5 different strategies with the completely open travel policy. So whatever the other measures being taken would proportionally affect all of these strategies equally.
Perfect. Thanks for that response, Lee. And then Jim, a question for Lee, and I'll answer this too. How aware of these findings, or how aware of these findings, or how aware of are the policymakers of these findings? I mean, I'll say your guess is as good as mine.
Yeah. Well, I've corresponded with the lieutenant governor, and he told me to reread the paper.
Well, which obviously you did, and you did a very great deep dive on this and broke it down excellently. So, maybe we can redirect him to watch this recording and to take a look again at your great breakdown, and maybe see what he thinks after his second review of the paper. So let me make sure I get Jim's question correct. So aside from the Lancet study, the false negative rate for the PCR itself calls Lieutenant Governor's evaluation of safe travels into question. Is that correct? So aside from the Lancet study.
Well, I think we have the prima facie evidence is that we've have all these variants now established in Hawaii. So they didn't even know about these variants before the beginning of the Safe Travels program. So they obviously, these were people that were infected, and that if they tested negative, weren't quarantined and exposed the population to these variants. So in terms of the metric of not overwhelming our hospitals, we could certainly say that the Safe Travels program has been successful in that we've allowed 2 million or so visitors to come to Hawaii, and the hospitals haven't been overwhelmed so far. But now that we have these extremely contagious variants, the B117 and the P1, which have the B117 is estimated to have 1.5 times the reproduction number of the old variants, and P1, the Brazilian variant, 1.5 to 2.5 times. We can expect that these variants will become the dominant ones in Hawaii, and it remains to be seen whether our mitigation measures and our vaccination rate will keep them in check. So we may be, it may be baked in that we're going to have some additional outburst in cases, and how big, we'll have to see. But it's not just the current rates of infection that we have to consider, but what we've baked in for the future because of allowing these variants into Hawaii.
Perfect. Great response, Lee. Definitely concur. Any other final questions for Lee or for myself before we call it an afternoon? Okay, thank you all for attending another Thursday HiPAM. I just saw Civil Beat posted an article saying that the governor is not expecting to change Hawaii's mask mandate anytime soon. And so a reminder that CDC is just providing guidance. It is still up to the individual governors and policymakers to determine what is best for their own state and stakeholders. So, be advised that while we have scientific evidence, there's still a political aspect as well, and a local response. So, just be aware of that. So once again, thank you, Lee, for this great deep dive. And we have this on a public forum now. So if you want to share, show this evidence that you've reread the paper. We have that evidence for the public to see. And thank you again, and thank you all for attending. And we'll see you guys next week Thursday. Have a great weekend, and stay safe, everybody. Aloha.
Aloha.